Hello everyone, this is Dr. Gobind Rai Garg. In this video, we will discuss the explanations of the questions which were asked in INI-CET May 2024. Okay, so let's start. The first question: which of the following neurotransmitter is released from SA node in response to increase in blood pressure? So you need to read the questions very carefully. जैसे मैं हर बार अपनी क्लास में कहता हूँ कि if there is slight mistake in reading a question, the answer may change. So you need to be very careful. I commonly give the example कि एक कॉमा का भी फर्क पड़ जाए तो आंसर चेंज हो जाता है, मीनिंग ही चेंज हो जाता है. जैसे कहते हैं चलो पूजा करते हैं या फिर चलो पूजा करते हैं, तो मतलब चेंज हो जाता है. तो यही चीज आपको ध्यान रखनी है. इफ यू डू नॉट रीड द क्वेश्चंस केयरफुली, आपके साथ पूजा हो जाएगा, आपका क्वेश्चन गलत हो जाएगा. सो बी वेरी केयरफुल. सो इन दिस क्वेश्चन they have not asked that which neurotransmitter is increasing the blood pressure. They are asking which neurotransmitter is released in response to increase in BP. So what they actually want to ask, so whenever there is increase in blood pressure, so there will be compensatory response by the body. So body will try to reduce the blood pressure. So how it will do? Yes. So whenever there is increase in BP, particularly mean blood pressure, that will lead to activation of a parasympathetic pathway via baroreceptors. So when parasympathetic pathway is activated, that will release acetylcholine, and this is helping to maintain the blood pressure. Similarly, whenever there is hypotension, there is activation of sympathetic system, that will release noradrenaline. Okay, so in response to increase in BP, what is released? Answer will be acetylcholine. So is it clear? So answer is acetylcholine, not noradrenaline. Is it clear? Very good. So coming back to next question: which drug used in treatment of leprosy can result in hyperpigmentation? So this is a characteristic question which can be asked. So answer is clofazimine. Clofazimine causes two characteristic side effects. One, it is causing hyperpigmentation, and second, it is causing dryness of the skin, which is known as ichthyosis. These are the characteristic side effects of clofazimine. Clofazimine, apart from leprosy, we know it is used in multibacillary leprosy, now POSI also. Apart from leprosy, where we use clofazimine? Yes, now it is approved in treatment of tuberculosis also. Now the other important drugs you can remember, dapsone, the main problem you need to remember is it causes hemolysis if we give in a patient with G6PD deficiency. Ofloxacin is a fluoroquinolone. We know, like every fluoroquinolone, it is avoided in pregnancy and children because of cartilage and tendon damage. And the rifampicin, we all know, is the most important anti-tubercular drug, most effective anti-leprosy drug. The main side effect of rifampicin include orange colored urine. Apart from that, it is a powerful enzyme inducer which lead to plenty of drug interactions. And everyone knows rifampicin is hepatotoxicity. So we need to be careful about liver function. Okay. So answer to this question is clofazimine. Next question: which is an adverse effect with the long-term use of intermittent teriparatide for osteoporosis? Yes, this is the question we discussed several times. Teriparatide, which is recombinant PTH 1,2,34. It acts by stimulating osteoblast. So it is used in osteoporosis. But problem is, it is recommended for maximum 2 years. The reason why it is not recommended for long periods, yes, it can result in osteosarcoma. So due to risk of osteosarcoma, the maximum duration for which we can use teriparatide is 2 years. So the answer here is osteosarcoma. And osteonecrosis of jaw is the main side effect of bisphosphonates like alendronate, risedronate. They cause osteonecrosis of jaw. Then loss of bone mass cannot be the answer because they do not cause loss of bone mass. They stimulate osteoblast. Teriparatide stimulate osteoblast, so it increases the bone formation. Okay. So answer is osteosarcoma. Next question: which anti-diabetic drug is associated with increased risk of UTI? This is the frequently repeated question. I hope everyone knows this. So we know that this is our nephron. Glucose is filtered freely by the glomerulus. but amount of glucose passing in the urine is almost zero. The reason is, in the proximal tubule, there is presence of a transporter which is known as sodium glucose transporter. The short form of that is SGLT2, sodium glucose transporter 2. The function of this is to help in reabsorption of glucose. So if we inhibit this transporter, glucose will not come back, so it will start going out in the urine. So this drug which inhibits SGLT2, it is used to produce glucose urea. So by causing the excretion of glucose, it will result in decrease in blood glucose, and that can be used to treat diabetes. So we can use SGLT2 inhibitors in treatment of diabetes. The mechanism is to cause glucose urea. And it is very obvious, if glucose has come in the urine, the bacteria will come to eat that. So the common side effect of this drug are UTI and genital tract infections like Fournier's gangrene. Okay, so which drugs are acting by this mechanism? Any drug whose name end with gliflozin, like canagliflozin, dapagliflozin, empagliflozin. So you can remember them, just add urine at the end. So that will tell everything, but it is telling glucose flows in urine. So these cause flow of glucose in urine. So that's why they cause UTI. So the question asked which cause UTI. So answer will be, they are asking which is ending with gliflozin. So answer is dapagliflozin. Yeah. Now pioglitazone, the major special side effect is increased risk of urinary bladder carcinoma. Urinary bladder carcinoma. Apart from common side effect of all the glitazones. What are the common side effect of all the glitazones? Yes, all the glitazones, they cause retention of sodium and water. All the glitazones are hepatotoxic. Hepatotoxic. Glitazones also increase the risk of fractures. So these are the common side effect of all the glitazones. Pioglitazone special thing is urinary bladder carcinoma risk. Sitagliptin is a DPP4 inhibitor. It is associated with pancreatitis. The main side effect is pancreatitis. And metformin, we know it is oral anti-diabetic drug, which is drug of choice for type 2 diabetes. And metformin, the main side effect is lactic acidosis. Apart from this, it can cause megaloblastic anemia. And many times the people develop unexplained diarrhea with the use of metformin. Okay, so these are the adverse effect of anti-diabetic drugs. So answer to this question, dapagliflozin. Moving to next question. A 55-year-old patient presents to clinic with a history of hyperglycemia and has a positive urine glucose test on 2 separate occasions in last 6 months. That means the blood sugar is not controlled. That's why it is coming in the urine. The patient has been diagnosed with type 2 diabetes. Physician is considering various medications to manage the patient's condition and prevent potential complications, including renal involvement. So which drug will not delay renal involvement? So that means which is not a renal protective drug, that is asked. So we'll discuss this option by option. The first option, SGLT2 inhibitors, gliflozins. So gliflozins, what is special to remember, apart from treating diabetes, they have 2 very important significant uses. One, they decrease the cardiac risks. Particularly, they are beneficial in congestive heart failure. So they are approved in treatment of CHF apart from diabetes also. So separate indication is congestive heart failure. That is very important thing to remember. Second important thing is they also delay renal dysfunction. So they prevent the kidney involvement. So these are the 2 special points about gliflozins to remember. Then finerenone. Finerenone. What is finerenone? Finerenone is a non-steroidal and aldosterone antagonist. So we know aldosterone antagonist, spironolactone, eplerenone, they are all steroidal. They are mineralocorticoid receptor antagonist. This drug, finerenone, is also same. That is mineralocorticoid receptor antagonist, but the special use of this is it can decrease the risk of kidney progression, decrease the risk of renal disease in diabetic patients. It also decreases the cardiovascular risks in diabetic patients. So this is a long-acting aldosterone antagonist which is specifically indicated for these indications. Then ACE inhibitors, ARBs, both of them can also decrease renal progression. This everyone knows. The renin-angiotensin pathway, when we stop, we can decrease the risk of renal progression. And the remaining answer is hydrochlorothiazide. That is the answer. Even if you do not know about other drugs, you could have easily answered. We know hydrochlorothiazide, including thiazides, every thiazide plus loop diuretic, they cause hyperglycemia. Rather than decreasing, they are increasing blood sugar and they will not decrease the progression of renal disease. Okay, so the answer is easy, hydrochlorothiazide, but other drugs you should know because the question has been asked now. Okay. Next question, anti-diabetic drug associated with unexplained diarrhea. We just discussed two important drugs are associated with the diarrhea which are used in diabetes. Most important among them is acarbose. Acarbose, it inhibits the absorption of carbohydrates. So when they are not broken, they can go out in the GIT. That can lead to diarrhea. But more importantly, it causes flatulence. Those carbohydrates can be utilized by bacteria to produce gases. So that is acarbose. And second drug is metformin. Metformin can cause unexplained diarrhea. Then other drugs, pioglitazone we already discussed, urinary bladder carcinoma. Sitagliptin we discussed, it causes pancreatitis. And glimepiride is a sulfonylurea, it can cause hypoglycemia. Okay. Now next question, a 45-year-old patient with a known allergy to penicillin presents with the enterococcal endocarditis. Read carefully, enterococcal endocarditis. The physician needs to prescribe an antibiotic but want to ensure that it is safe in a patient with penicillin allergy. Penicillin allergy. Patient has allergic reaction to penicillin. So which drug can be used safely in this patient? Now read very carefully. If you do not read carefully, तो आपके साथ पूजा हो जाएगा. You know, penicillin allergy we discussed several times. Azithromycin. So azithromycin says, Aji tera naam to bata. Why it is saying Aji tera naam to bata? Because this is a drug which has two properties which are different from penicillins. The first property is it do not show cross allergy. Cross allergy. So by looking at this, we tend to mark azithromycin. क्योंकि क्रॉस एलर्जी नहीं करती है, तो अगर हमने पूरा नहीं पढ़ा क्वेश्चन तो पूजा हो जाएगा. Azithromycin is not the answer here. Why? Because it has second property also. Unlike penicillin, it is only effective against gram-negative bacteria. It is not effective against gram-positive bacteria, and the gram-positive bacteria enterococcus. So here the patient is having enterococcal endocarditis. So we need to treat the person. So we need to give a drug which is effective against gram-positive also. So azithromycin is out. Ceftriaxone is a cephalosporin. It shows cross allergy. We know all beta-lactams, they show cross allergy except azithromycin. Piperacillin is again a penicillin, will show cross allergy. So answer will be vancomycin. It is not a beta-lactam, so it will not show cross allergy. And second, it is mainly effective against gram-positive bacteria, including MRSA and including enterococcal bacteria. Okay, so the answer here is vancomycin. Read carefully, पूजा हो जाएगा नहीं तो आपके साथ. Okay, next question. Which diuretic is correctly matched with site of action? That is an easy question. We know diuretics and their site of action. Quickly revising. So in the proximal tubule here, the diuretic which work are carbonic anhydrase inhibitors. Their name end with the zolamides. Then in thick ascending limb of loop of NLA, the diuretic working are loop diuretics like furosemide, torsemide like drugs. In distal tubules, the diuretic working are thiazides. We know in this loop of NLA we have sodium potassium 2 chloride pump, whereas in the distal tubule we have sodium chloride pump. Okay, so we have sodium potassium 2 chloride pump here, we have sodium chloride pump here. So loop inhibits sodium potassium 2 chloride, thiazide inhibits sodium chloride pump. Then in the collecting duct we have sodium epithelial sodium channels. So this can be inhibited by amyloride and triamterene. Whereas here in the pump inside we have aldosterone receptors also. So aldosterone can be blocked by a spironolactone, aldosterone antagonist. So both of these groups are classified as potassium sparing diuretics. Okay. Now, what is remaining? Remaining is osmotic diuretics. Osmotic diuretics are usually non-specific in their site of action, but primary site is loop of Henle. Main site is loop of Henle, but they can work anywhere in the nephron, particularly in the early nephron. Okay. So now coming to the question, which is correctly matched they are asking. Osmotic diuretic collecting duct, no, particularly in the early segment, little bit in the collecting also, but mainly in the early segment. So this is wrong. Carbonic anhydrous proximal tubule, yes, that is correct. Thiazide loop of Henle, this is wrong. Aldosterone antagonist distal tubule, no, they are working on collecting ducts. Okay? So the answer is carbonic anhydrase inhibitor, proximal tubules. Okay, now moving to next question. Most potent natural estrogen is. So again read very carefully, नहीं तो पूजा हो जाएगा. The question is natural estrogen, natural. Otherwise, very potent is ethinyl estradiol or conjugated estrogen. But important thing is conjugated estrogen or ethinyl estradiol is synthetic. So it cannot be the answer. Okay? So these are the three natural estrogen. Estrone is called E1, estradiol is called E2, and estriol is called as E3. Out of them, most potent is estradiol or E2. Another thing you can remember, major estrogen in the menopausal period is E1, that means estrone. Major estrogen during the reproductive age group, 15 to 45 basically, is E2, and during pregnancy the major estrogen is E3. Okay. So you can remember that easily. All of these you can remember easily. Estrone contains 1, so it is E1. Estradiol is di means 2. Estriol is tri means 3. Okay. Now you can remember that most of the time in the reproductive period, the female is with his partner, her partner. So they are 2. So E2 is most in reproductive period. Then during pregnancy, the third one comes. So E3 is more in pregnancy. And after that, in the menopausal period, सब छोड़ जाते हैं, बेचारी अकेली हो जाती है. So in menopausal period, it is E1. Okay. So most potent estradiol. Okay. Next question. A 30-year-old patient presented with fever, cough, and tenacious white sputum, tenacious sticky sputum, thick sputum. Which should be used? So basically, for cough, there are two types of drugs we can use. One are known as cough suppressant, which are known as antitussives. They stop the cough reflex. Whereas second are expectorants or mucolytics. They will break the mucus, So antitussive drugs like codeine, dextromethorphan, they stop the cough. Whereas mucolytic drug like bromhexin, ambroxol, they break the mucus to make it thin. Now, when there is thick sputum, we want to make it thin so that it can be removed out. So these are mainly used in productive cough. Remember, productive cough, we should not stop. We want to help in removal of that cough easily. Whereas antitussives, they are used in dry cough. We want to stop the cough here. Okay. So now coming to options, this person has tenacious sputum, that means productive cough, thick cough. So we want to break that. We want to give a mucolytic drug. Now coming to option, mucolytic is given, but with the dextromethorphan, no sense. We do not want to stop the coughing. So this is out. Codeine is cough suppressant. We will not suppress the cough. Against dextromethorphan, we will not give. So answer will be syrup bromhexin only. Okay. Next question. A 30-year-old patient present with progressive dyspnea at rest and on exertion. Patient also has history of heart failure. So this is signifying heart failure. Lab tests show a fasting plasma glucose of 136, hemoglobin 13 gram, and HbA1c 7.8%. So indicating poorly controlled type 2 diabetes. Physician need to select appropriate anti-diabetic. So basic question is easy. The question is, which is a good drug for diabetes with CHF? So we already discussed which drug has beneficial effect on cardiovascular system. Yes, it is gliflozins. So the answer is gliflozin. Okay. So other drugs we have already covered. Next question. Drug resistance is most commonly seen with which sexually transmitted infection? So this is the easy one question. We know if you remember my lectures, we discussed for gonorrhea earlier, very earlier, penicillin G was drug of choice. When we remembered the mnemonic as last mango, we say go is gonorrhea. So penicillin G was the drug of choice. Then most of the gonococci become resistant. So now the drug of choice for gonorrhea is ceftriaxone. Ceftriaxone is now the drug of choice, because we said we have made the mnemonic last mango, so go has gone. Bura maan gaya, chala gaya bhai. So now the drug of choice for gonorrhea is ceftriaxone. So this is just to indicate that there is significant drug resistance in gonorrhea. Other usually do not show drug resistance, like chancroid and donovenosis. We commonly used azithromycin, or we can also use doxycycline. Syphilis, we know benzathine, penicillin G is a drug of choice. Okay, so gonorrhea is the one where resistance is very common. Okay. Next question, inhalational agent of choice in children. This is the one because they are children, so they are very fond of sweets. So we will give sevoflurane, which start with S, means it is sweet. Whereas others have pungent odor, so they are not suitable in children. Particularly desflurane, it is highly irritant to respiratory pathway. So these are not suitable. Sevoflurane is a drug of choice in children for inhalational agent. Okay. Which is PCSK9 inhibitor? Repeat question, several times asked. PCSK9 is a compound which help in degradation of LDL receptors. Degradation of LDL receptors. So what basically happens is, this is liver, this is blood. So LDL cholesterol is circulating in the blood. We want to decrease that cholesterol. So how that is decreased is, there is increase in number of LDL receptors by different drugs on the liver. So what these LDL receptors do, they will pick up LDL cholesterol from the blood. So the LDL will decrease in the blood. That is the mechanism. Now after doing some work, everyone tires. So LDL receptor also tires. So LDL receptors start resting. So it go under the surface of the membrane. From the membrane they go inside, and here they are resting. Now when they are resting, one of the person who was walking through, which is called as PCSK9, it comes and he says that, why you are wasting time now? Let's move. Let's go and let's have fun. So it bind to LDL receptor and it takes him for a ride. So let's go, let's roam about in the streets, let's have fun. So it goes there, and after some time, what they do, they will take up LDL receptor inside the lysosome. So they will leave LDL receptor inside the lysosomes, and LDL receptors are degraded. So basically PCSK9 breaks LDL receptors. So we thought that it is breaking LDL receptors. So if we stop that, LDL receptor will increase because they are not broken down. And when they increase, they will increase the uptake of LDL cholesterol. So that actually happened. So what we did, we made monoclonal antibodies against PCSK9. And the drugs are evolocumab and alirocumab. So I told you, from the name you can remember, they are used when there is over cholesterol. These are monoclonal antibodies used when there is over cholesterol, excessive cholesterol. Okay, so this is the answer here, evolocumab. We know ezetimibe is intestinal cholesterol absorption inhibitor. Avinacumab is a new drug. This is the only drug which decreases cholesterol without using LDL receptor, without decreasing LDL receptor. Increasing LDL receptor density, works independent of LDL receptors. Everolimus is not an this PCSK9 inhibitor or even a hypolipidemic drug. It is rather a immunosuppressant drug. Okay, so answer is evolocumab. Moving to next question. This I taught you very clearly. So this is basically about the Lineweaver-Burke plot. So quickly revising about Lineweaver-Burke plot. So this is basically a graph between 1 by velocity on the y-axis and 1 by substrate concentration on the x-axis. So from this graph, you can tell which type of inhibition it is. The two most important you need to remember is competitive or non-competitive. Suppose this is a drug. This is a graph of without inhibitor. So we have not given any inhibitor, then the graph is like this. So this is shown without inhibitor, the yellow line. Okay? Now we give an inhibitor and see what happened to the graph. Suppose the graph comes like this. The graph comes like this. Number one drug. Second thing can happen is graph can be like this. Number two drug. Third and fourth we'll discuss later. These two you must remember. The first one is the drugs are meeting on y-axis and they are different on x-axis. Remember, when they're meeting on y-axis means Vmax is same. Remember, y-axis representing velocity, 1 by velocity. So Vmax is same, only the Km is different. Remember, x-axis tells about substrate concentration, that means Km. So what happens? Km increases, Vmax remains same. And this is seen in this is seen in competitive inhibition. Competitive inhibition. So it's easy to remember. You can remember when the graphs cross. Remember, the graph is crossing here. So when the graph cross, so that means C means competitive inhibition. Or in other ways, you can remember whenever there is competition, you have to cross someone to go further. So that is competitive inhibition. Now, if we see the B-type graph, second graph, here they are meeting on x-axis, but they're different on y-axis. So when they're meeting on x-axis, that means Km remains same, but Vmax decreases. Vmax decreases. So this type of graph is competitive and non-competitive. We know in a non-competitive inhibitor, the Km remains same, but the velocity changes. So it is a non-competitive inhibitor. These two you must remember. So simply remember, if they're meeting on x-axis, then that means there is no competition. So you easily remember that thing, कि मेरे यार दाता कोई competition नहीं. So x. So this is x-axis. जब तुम्हारी x की बात हो रही है तो कोई competition ही नहीं है. So there is no competition. So when they are meeting on x-axis, there is no competition. But when they are meeting on y-axis, that means they are crossing, then it is a competitive inhibitor. Clear? Now, third type of graph can be uncompetitive inhibitor. If you see in uncompetitive inhibition, there are parallel lines, they do not meet. Uncompetitive inhibitor, the graph will be like this. This is normal. And uncompetitive inhibitor will be parallel to this. Uncompetitive inhibitor will be parallel to this. So number 3 will be uncompetitive inhibitor. Clear? Number 3 will be uncompetitive inhibitor. And if they do not meet at any point, like this is a normal graph which we draw, and if they are like this, then it is mixed inhibition. Number 4 is mixed inhibition. You don't need to remember 3 and 4. Just remember 1 and 2. So now coming to question. So tell me, which is this graph showing? What is this graph showing? Drug A. So drug A is meeting on y-axis. They are crossing each other. So because they are crossing, so it is competitive inhibitor. So A is competitive. If you see Y they are not meeting. They are starting from one point that is on the x-axis. So X data koi competition nahi. So they are non-competitive. So A is competitive, B is non-competitive. So coming to drug A is competitive, B is non-competitive. So answer is B. Clear? You understand this concept? Yes, very good. Now moving to next question. Cannabinoids are not approved for treatment. So one of the cannabinoid known as cannabidiol. Cannabidiol, it is approved in treatment of epilepsy. Particularly in epilepsy in 3 situations, seizures in 3 situations. First, they are approved in seizures in Dravet syndrome. Second, they are approved in treatment of seizures in Lennox-Gastaut syndrome. And third, seizures in a patient with tuberous sclerosis. So basically, cannabidiol is used in epilepsy. So if we see the options, all 3 are given: Dravet syndrome, tuberous sclerosis, Lennox-Gastaut. So by ruling out, the answer is Rett syndrome. It is not effective in Rett syndrome. Right? Trifintide, that is the drug which is used in Rett syndrome. Now coming to next question. A 50-year-old patient with a history of chronic pulmonary aspergillosis was treated with voriconazole medication for 2 weeks and comes to clinic for follow-up. specific guidelines but consideration with voriconazole. So basically, what is true about voriconazole? So last 3 words are the question. What is true about voriconazole? It should not be given with pyrazinamide. No, there is no such interaction. In fact, what is important to remember? It should be avoided with rifampicin. Rifampicin increases its metabolism. Pyrazinamide, no interaction. It should be taken empty stomach. Again, wrong. It is usually given 1 to 2 hours after meals. Usually it is given 1 to 2 hours after meals. It requires therapeutic drug monitoring. No, usually we do not require to measure the plasma concentration. Yes, it is given as a loading dose. First, usually most of the patient require a loading dose followed by maintenance dose. So that is the answer, used as a loading dose. Loading dose. Okay. Now moving to next question, which act as inhibitor of HER1? So remember, there are 2 types of HER. HER is human epidermal growth factor receptor. Human, H is human, E is epidermal growth factor, R is receptor. So there are 2 types of HER. One is HER1 and second is HER2. HER2. Now HER2, you can remember, we have HER2. HER means she. 2. So she has 2 breasts. So HER2 inhibitors, they are used in breast cancer. So HER2 inhibitors are used in breast cancer. Whereas HER1 inhibitors, they are used in many types of cancers, particularly non-small cell lung cancer, but also for many other cancers. Now, HER2 inhibitors are commonly asked in the exam, so you need to be aware about them. So the most important drugs like trastuzumab and pertuzumab. We discussed in our class also trastuzumab, pertuzumab. So these drugs are cardiotoxic. I told you how to remember that. It's easy. So trastuzumab, instead of T, if we write B, it become breastuzumab. So used in breast cancer. And you can remember trust. So if you trust someone, the heart will be broken. So trastuzumab cardiotoxic है, heart को affect करती है. तो मैंने बोला था कि ब्रेस्ट वालों पे ट्रस्ट नहीं करना, बट पर तू फिर भी करेगा, ठीक है, पर तू फिर भी करेगा, that means you will also develop cardiotoxicity. So trastuzumab, pertuzumab. Then we have a tyrosine kinase inhibitor called as lapatinib, that is also HER2 inhibitor. So all of these are HER2 inhibitors. Then HER1 inhibitors, these include drugs like cetuximab, panitumumab, and necitumumab. So these are HER1 inhibitors. Now coming back to our question, all act as inhibitor of HER1 except. So you can answer this question simply by saying that pertuzumab. Pertuzumab, remember, pertu फिर भी करेगा. It is HER2 inhibitor, not 1 inhibitor. So that is the answer. So other 3 drugs, panitumumab, necitumumab, cetuximab, they are all HER1 inhibitors. Okay. Now next question. A 60-year-old male patient underwent surgery under GA. Rocuronium was used. Rocuronium was used, and medical team need to reverse which is the fastest reversal agent. So basically they are asking the reversal agent of muscle relaxants. So in particular, most commonly used agent is neostigmine. Neostigmine. Remember, neostigmine is most commonly used, but it can cause cholinergic side effects. So to avoid them, we add atropine. Atropine. But another important thing, it is relatively slower acting. So for that, we developed a second group of drug which is known as selective relaxant binding agent. Selective relaxant means muscle relaxant binding agent. Particularly, it is used for rocuronium and vicuronium. And that drug is Sugamadex. Sugamadex. So what is special about Sugamadex to remember? It is the fastest reversal agent for these 2 drugs. Rocuronium, vicuronium, fastest reversal agent is Sugamadex, and the advantage is no cholinergic side effects because it is not increasing acetylcholine. Okay, so now the question is fastest agent. So answer will be Sugamadex. Okay. Next question. So it is fetal lung maturation, the dose of betamethasone or dexamethasone. This we have discussed 100 times earlier. So quickly revising, we have betamethasone, we have dexamethasone. Both are given by intramuscular route to the mother. Now what is this? Easy to remember. Beta start with B. B means second letter. So total we will give 2 doses. Dexa start with D means fourth letter. We will give total 4 doses. Now the total dose of both of them is 24 milligram. If you are giving 2 doses, that means the dose is 12 milligram. If you are giving 4 doses, means it is 6 milligram. Then total duration is 48 hours. So if 2 doses are given, so you will give 24 hourly. Whereas if 6 milligram is given, you will give 12 hourly. So that is easy to remember. So now choose which is for fetal lung maturation. So Dexa 12 into 2, 24, 24 into 2, 48. So that is wrong. D2. This is wrong. D4, this is correct. Now see, 6 4s are 24, 12 4s are 48. This is the answer. B2 is right, but 12 into 2 is 24 only. Cannot be the answer. B4 is wrong. Okay, so the answer is B. Dexamethasone 6 milligram, 12 hourly, 4 doses. Okay. Next question. Which is used for cyanide poisoning? So what we discussed, cyanide. Cyanide is a poison. It has very high affinity for an enzyme called as cytochrome oxidase. The cytochrome oxidase is the enzyme which helps in production of ATP. So when cyanide bind to this, there is no production of ATP. The person become energyless. So what we do, we want to remove cyanide from this. But how we will remove? So what we will do, we will send a friend of cyanide, which is very fast friend. So that cyanide will leave everything and go to him. Uske gale milne nikal jayegi. So what is that friend? That friend is methemoglobin. So whenever methemoglobin comes, cyanide will leave cytochrome oxidase, usko dhokha de degi, and it will bind to methemoglobin, that will form cyan-methemoglobin. But why to give methemoglobin? We know that in the body plenty of hemoglobin is there. Why don't we convert hemoglobin to methemoglobin? Yes, that can be done, and that is done by a drug known as nitrite. We can use amyl nitrite or we can use sodium nitrite. So nitrites convert hemoglobin to methemoglobin. Methemoglobin will remove cyanide. So these are antidote for cyanide poisoning. So although we have formed cyan-methemoglobin, we have removed cyanide from the cytochrome oxidase that started working, but cyan-methemoglobin is also very, very toxic. So what happened? We have removed the toxicity of one compound, but second compound become toxic. Asman se gire khajur pe atke. So what we will do? Now we will want to remove cyanide from this also. So how we will do? We will give sodium thiosulfate. So when we give sodium thiosulfate, the cyanide now will bind to this compound and remove from methemoglobin. So methemoglobin become free and it becomes sodium thiocyanate. And sodium thiocyanate can be excreted in urine. So this is how to treat cyanide poisoning. We give one of these plus we give sodium thiosulfate. Okay, so this is one. Second we can use for cyanide poisoning is hydroxycobalamin. Hydroxycobalamin again, it will remove cyanide from the cytochrome oxidase and bind here. So it becomes cyanocobalamin. So cyanide basically बहुत बेवफा है. ठीक है, जहां पे उसको अच्छा मौका मिलता है वो वहां चला जाता है. नॉर्मली साइटोक्रोम ऑक्सीडेज के साथ दोस्ती निभाता है, बट जैसे ही उससे ज्यादा अमीर आदमी आता है उसके साथ चला जाता है. Clear? So that is important. So if you come back, amyl nitrite we can use, sodium nitrite we can use, thiosulfate we have to use, glyceryl trinitrate is used in angina. It is not used in cyanide poisoning. So answer is 1, 2 and 3. So that is the answer. Okay. Moving to next question. Which is a suicide inhibitor? First of all, what do you mean by a suicide inhibitor? Suicide inhibitor, basically, this is a substrate. This is the enzyme. So enzyme is working normally on substrate. So what happens? This is the substance or the drug whose structure is similar to substrate. So it will bind to the enzyme. So normally enzyme will start acting on this. It bind to active site. So enzyme will start acting on this. So it will be metabolized to produce some product. And this product will inhibit the enzyme. So that means enzyme has unintentionally converted a drug which is inactive compound to a product which can inhibit the enzyme itself. तो एंजाइम ने खुद ही सुसाइड कर लिया, ठीक है। तो एंजाइम ने एक सब्सटेंस को, एक दवाई को जो कि नॉर्मली एंजाइम को इनहिबिट नहीं करती, हैज मेटाबोलाइज्ड इट टू मेक अ प्रोडक्ट व्हिच विल इनहिबिट द एंजाइम इटसेल्फ, सो दैट्स व्हाई इट इज नोन एज सुसाइड इनहिबिटर, and this will inhibit it permanently, irreversibly. So most important property of suicide inhibition is this is irreversible inhibitor. So it will form a covalent bond, that's why it is irreversible inhibitor. And second thing, it convert an inactive compound to active compound which inhibit that enzyme. Is it clear? That's why it is called suicide inhibition. So which are the suicide inhibitors? We have plenty of drugs. So I made a mnemonic of the important drugs for you to remember. So they are suicide inhibitors. So how they commit suicide? So we remember suicide by fan. So S means spironolactone. U is uric acid inhibitor. So which is the rate limiting enzyme? Yes, xanthine oxidase. So inhibitor of that allopurinol. I is ibrutinib. Ibrutinib is a tyrosine kinase inhibitor used in lymphomas. C is clavulanic acid. I is isocarboxazide. Not only this, all MAO inhibitors, almost all MAO inhibitors, including MAO B inhibitors also, like salazilin, rasazelin, non-specific inhibitor like isocarboxazide, phenelzin, chlorzelin, parizilin, all of them, except the RIMA, reversible inhibitor of MAO, which was, yes, moclobemide. Then we have D for disulfiram, E for exemestane, eflornithine, B is beta-lactam drug, particularly penicillin, F is 5-fluorouracil, A is aspirin, and N is norethindrone. These are the important ones you should remember. So coming to the question, norethindrone yes, ritonavir no, spironolactone yes, benzbromaran no. Remember, ritonavir is a competitive inhibitor of protease. So competitive inhibitor. Remember, these are non-competitive, or we can say irreversible. So ritonavir cannot be the answer. Benzbromaran is a uricose uric agent. It is not a suicide inhibitor. So answer is 1 and 3. Okay. Next question, which anticoagulant require coagulation profile monitoring? So here, which require monitoring? We'll see. Among the oral anticoagulant agents, only one drug require monitoring, that is vitamin K antagonist. So vitamin K antagonist like warfarin and dicumaro, these require monitoring, whereas new oral anticoagulants like hexabans and dabigatran, they do not require monitoring. No monitoring not required. Monitoring is required for warfarin like drugs only. Whereas for injectable drugs, if we see injectable drugs, we have indirect thrombin inhibitors and direct thrombin inhibitors. Indirect thrombin inhibitors include unfractionated heparin, low molecular weight heparin, and fondaparinux. We all know unfractionated heparin require monitoring by APTT, whereas these two require no monitoring. So that means enoxaparin like drugs do not require monitoring, fondaparinux do not require monitoring, whereas direct thrombin inhibitors, the drugs whose name end with rudin, like lepirudin, vivalirudin, hirudin, they are direct inhibitors, the name tells, as well as drugs like argatroban and malagatran. These also require monitoring. Yeah. So important to remember, warfarin require monitoring and heparin require monitoring unfractionated, and rudins require monitoring. Okay. So coming back to question, enoxaparin is a low molecular weight heparin, so no monitoring is required. Fondaparinux, no monitoring required. Dabigatran is oral drug, monitoring is not required. So answer is lepirudin. Okay. Moving to next question. A 30-year-old woman has experienced the loss of her newborn. She is currently producing breast milk, leading to discomfort and risk of developing a breast abscess due to milk stasis and incomplete emptying. Obviously, if the stasis occur, there can be infection. So which can be used to this? So there are two types of drugs we can use. One, which is decrease the production of milk. Second, which increase the ejection of milk. Milk comes out of the breast. So this is done by oxytocin. So it will not accumulate in the breast, and so when it is not accumulating, there will be no homeostasis, and the drug which decrease the production are dopamine D2 agonist. So D2 agonist like bromocriptine, cabergoline, they decrease the production of milk, secretion of milk. So these will be used for this patient. If you see oxytocin is not in the option, so the best answer will be cabergoline. Okay. Moving to last question. Many GPCR receptors act by increase in cyclic GMP. So how cyclic GMP work? Basically what happens, this is cell. On the surface of the cell we have a receptor, G protein coupled receptor. And near the receptor a protein is present which is called as G protein. So whenever we give a drug bind to the receptor, that will activate the G protein. G protein will activate an enzyme called as adenylate cyclase. Adenylate cyclase will convert ATP to cyclic AMP. Cyclic AMP will activate protein kinases. And when protein kinases are activated, kinase means phosphorylate. So they will phosphorylate target proteins. And that will lead to action. We know the enzymes are controlled by phosphorylation. Some become active by phosphorylation, some become inactive. So that's why the action will come. Okay, so this is the pathway of cyclic AMP. So if we see the sequence, they are asking which is the correct sequence. So first of all, the drug bind to the receptor, then receptor is activated, that will activate adenylate cyclase. So first thing will be activation of adenylate cyclase. Then second thing, activation of protein kinase, and then adenylate cyclase is converted to cyclic AMP. That will activate protein kinase A, and that will result in phosphorylation. Clear? So the sequence is 1, 3, 2, 4. 1, 3, 2, 4. So that is the answer. Okay. So that is all about the questions which are asked in the INI-CET May 2024. Thank you very much.